Welcome to part 3 of the Advanced Cardiac Life Support module. In this module, we are going to explore some of the key medications used in critical care, focusing on their indications, dosages, routes of administration, mechanism of action, and those potential side effects. The goal here today is to not only understand the medications, but also to be able to apply the knowledge in managing specific cardiac emergencies. By the end of this presentation, hopefully you guys will be equipped to select and administer the appropriate medications based on the different ACLS algorithms and clinical scenarios, which will hopefully enhance your readiness for the NCLEX and real-world practice. So let's get started about epinephrine. Epinephrine is one of those super important medications in ACLS. It's like your number one med, right? And it's primarily used during cardiac arrest scenarios such as VFib, VTAC, pulseless electrical activity as well, PEA, and asystole. The recommended dosage is 1 milligram administered via IV or intraosseous IO every 3 to 5 minutes during resuscitation efforts. Epi works by increasing the heart rate myocardial contractility, which helps restore that effective cardiac rhythm. In addition, it also causes vasoconstriction, which can help improve blood pressure and perfusion during CPR. However, be cautious of the potential side effects like tachycardia, hypertension, and other arrhythmias that can come from using it in your patient. So just a reminder of our picmonic down there. So for epinephrine, imagine that the battery is the epinephrine and there's like a bear chasing a person, right? So epinephrine is the powerful battery charging up the heart's energy. The bear chasing the man represents the surge of adrenaline epinephrine provides, which boosts your heart rate, boosts blood pressure, just like a battery boosts power. In emergencies, epinephrine jolts the heart and the circulatory system into action, especially in cases like cardiac arrest, and we also use it in severe allergic reactions. Administered typically 1 milligram IV, it increases the heart function and blood pressure, just like we just talked about. But again, those side effects, keep those in common in your mind. So they are tachycardia, hypertension, and anxiety also might occur. So just like an intense rush that you feel when you would be chased by a bear. So using the MED method for learning epinephrine, okay, what are you going to check before, okay? So monitoring before administration, you're going to check for signs of cardiac arrest before you give it. So before giving it, you need to confirm that the patient is indeed in cardiac arrest. Look for signs such as lack of pulse, unresponsiveness, and absence of normal breathing. You need to confirm this because epinephrine is used specifically in those kind of emergencies. Then you also need to verify IO and IV access because how are you going to give it, right? So it needs to be administered directly into the bloodstream. So you need to confirm that your access route is secure. Then you need to make sure that they're on a cardiac monitor before you give it because you need a baseline heart rate and blood pressure. So if there's no pulse, they obviously have no blood pressure and no heart rate, right? But they need to be on a monitor before you give it so that you can watch and monitor those things. So before administering it, take note of any blood pressure and heart rate that you may or may not have. And then so after you give it, so what are you going to evaluate for? So you should have ROSC, so return of spontaneous circulation. So that's the primary goal of epinephrine in cardiac arrest is to restore the circulation in your body. Primary goal. So check the patient's heart rate, see if it started beating again, if there's a detectable pulse. Okay, that's the most direct indicator of the effectiveness of epi. You're also going to observe changes in blood pressure and heart rate. So if the heart starts beating, obviously the heart rate should go up and the blood pressure should go up, okay? And then you also want to look for some of those side effects. So some of those detecting reactions that might occur, okay? So some of the unwanted side effects would be tachycardia, hypertension, maybe new arrhythmias. So you want to be monitoring for those. And there's no specific reversal agent for epi. So you're just going to manage any effects symptomatically, just kind of a holistic approach, okay? So now let's talk about amiodarone. So remember my amio slow snail? Okay, so amiodarone is an effective antiarrhythmic medication used to treat ventricular fibrillation, pulseless VTAC, and stable VTAC, so both VTACs. The initial dose is 300 milligrams administered via IV push with a possible repeat dose of 150 milligrams if needed. Amiodarone works by prolonging the action potential during the refractory period in the cardiac tissue, which helps stabilize abnormal rhythms. So in other words, when you prolong the action potential, you're prolonging the ability of the electricity to go through the cells, which when you prolong it, that means you're slowing it down. Okay? So be mindful of the side effects, which could be hypotension, bradycardia, potential pulmonary toxicity. Okay? And so if your patient has pulmonary toxicity, what would you see? They might be coughing or having dyspnea. And so those are some of the things you would look for after you gave amiodarone, if it wasn't there before, but after. Okay, so the little picture, the little slow snail, just remember it's helping you remember to slow it down. So amio slow, the snail, represents the medication's ability to decelerate or lower the heart rate, especially in conditions like VTAC and AFib. Just like how the snail moves slowly, amiodarone helps slow down the heart's conduction and stabilize its rhythm. Okay, so that's just your memory trick. So the med admin, before we give it, remember again, part of before you give it is the 5 rights. So 5 rights, check. You made sure it's right patient, right dose, right time, all those things. Okay, right? So we also need to, before we give it, make sure that we're giving it for an arrhythmia that actually exists. So it's primarily used to treat things like VTAC and VFib, right? So before you give it, ensure that there's actually an arrhythmia to give, because what's the point if it's normal sinus rhythm, which is not the case. But anyways, so you also want to make sure that you're checking that heart and blood pressure before, kind of same reason, because you want to make sure, because this amiodarone, right, is going to slow things down. So if it's already slow, would we give it? No, right? Because it's going to slow it down even more. So if the heart rate is 50, we're not going to give it. Okay, so contraindications. So, to evaluate the effectiveness, okay, you are going to monitor for, the primary goal of it is to convert the abnormal rhythm into a normal sinus rhythm. So obviously, if you see on the monitor that the patient's rhythm is now normal sinus rhythm, you are great, right? Like we did what we wanted. So you're going to be observing the patient's EKG to see if there's a return to normal rhythm, at least an improvement in the cardiac cycle. You also might, if the heart was beating fast, the patient may be breathing faster. So now all of a sudden they're breathing a little bit more slow, like they're a little bit more calm. Maybe they had anxiety before. Now they don't, because they had the tachycardia that was causing them, some chest pressure and anxiety. Now they don't have it anymore because we slowed it down. Okay. So then let's talk about like looking for side effect, detecting those reactions that we don't want, right? So some of those potential side effects include hypotension, bradycardia, and respiratory symptoms like difficulty breathing and cough. So if somebody has hypotension and bradycardia, they could have been wide and awake, and now all of a sudden they're just a little out of it, maybe just a little slow to respond, a decreasing level of consciousness. That's not what we want, because that might mean that we dropped the heart rate too low, that the blood pressure is too low, and now they're not perfusing their brain. So that would not be good, right? So there's no reversal agent. Just remember that. We would just do supportive therapy if for some reason the patient had a reaction or we overdosed them for some reason. So now lidocaine. This is a new one that we haven't discussed yet. So what I want you guys to do is look at our cool little lava lamp for lidocaine lava lamp. Okay, so what this is imagine a lidocaine lava lamp that keeps your heart rhythm smooth and stable. You see like my little yoga looking heart, like he's chill and he's like in a total vibe going on with this lava lamp, right? Okay, so lidocaine is used primarily for ventricular arrhythmias, providing effective management in cases such as like VTAC. The dose is 1 to 1.5 milligrams per kilogram IV push, okay? So, and you can repeat it if necessary. What lidocaine does is it stabilizes the cardiac tissue, okay? So it suppresses abnormal electricity activity in the heart. So it's chilling the heart out, okay? Like we're in, like I said, like a groovy, chill, lava lamp kind of setting mood, like yoga studio, think that, okay? Potential side effects include drowsiness. If we're chilling you out too much, you might be a little drowsy, confusion, but it also can lead to seizures, which can occur due to its central nervous system effects. Monitoring for these symptoms is crucial to ensure the patient's safety. So again, that lava lamp, okay, inside, it's like smooth flowing. You know how like the lava, like in the lamp, just smoothly goes up. Think of the cardiac rhythm, where instead of it going all crazy and chaotic, we're going to smooth and chill out that cardiac rhythm so that it's nice and happy, right? So it's just kind of a way to remember lidocaine is like a chill to the heart rate. Okay, it's my way of remembering it anyway. So lidocaine. So those things that you want to monitor before, right? We want to, make sure that there's ventricular arrhythmias before we give it. And we're also going to do a baseline neurological status. If they're already depressed neurologically, this could cause it to be depressed even more. And that would, if you lose even more neural function, you could lead to issues with like airway. You wouldn't be able to like protect your airway. You know, you're putting them you're sedating them too much, pretty much. Okay. So lidocaine also is metabolized in the liver. So we want to make sure that the liver is functioning properly before. We're going to check liver enzymes before. Well, if it's an emergency, you're just going to give it, but afterwards you want to check it. If you were giving this like IV in a controlled setting, I would want to check to make sure that the liver enzymes are okay before we give it, okay? Because it can cause, like I said, issues with the liver. So how do I know lidocaine is working? Obviously, if I look on the monitor and there's a reduction in those ventricular arrhythmias and the cardiac electricity on the monitor is now stabilized. Yay, it worked, right? So again, it's going to cause the patient may have been anxious before, and now they're kind of a little bit more like in control. Their heart's not going as fast, right? But we also might, standing in the doorway, see that mental status decline a little. So we would know it's working if they become like a little drowsy, right? So now if they become too drowsy, that's signs of possible toxicity, okay? And we want to be making sure and looking for, say, we want to make sure seizure precautions are in place. You have suction at the bedside, oxygen at the bedside, because if you even think for a hot second that this patient might end up having a seizure, you better be prepared to protect that airway if they do start seizing. So those are some of those safety precautions you want to put in place. You also want to be checking reflexes because, again, it can depress the central nervous system. And again, there's no specific reversal agent, so we're just going to manage the symptoms holistically. Atropine. So you remember my pointy trees for the heart rate. It's speeding up the heart rate, right? So it's used to treat bradycardias where the heart rate's too slow. Standard dose is 1 milligram IV push every 3 to 5 minutes with a maximum of 3 milligrams. So if you're doing 1 milligram every 3 to 5 minutes, you do it every 3 minutes, you're going to be done in 9 minutes. If you're doing it every 5 minutes, you're going to be done in 15 minutes. Atropine's not one of those things that we're going to be pushing for hours on end, okay? So some of those common side effects include dry mouth, blurred vision, urinary retention. So I mentioned this in another lecture, but atropine will also dry up secretion. So that's why it leads to that dry mouth and blurred vision too, like eyes. Anything that produces fluids in your body, like your mouth, your tears, your eyes, everything can kind of get dried up with atropine. So that is a side effect that we are aware of, okay? But also can cause urinary retention. So the med admin, before we give it, again, if they need it, you're going to give it. But if you have time to think, what do we need to check before? Obviously that they're bradycardic, because I'm not going to give it to them if their heart rate is 110, right? We're not going to give that. So we want to make sure that the heart rate is on the lower end of normal and lower than normal before we give it, right? So baseline vital signs, because this is going to cause vital signs to go up, blood pressure to go up, heart rate to go up, okay? And if you have time and patient has narrow angle glaucoma, we're not going to give it. But, if we're going to err on the side of caution, you may not know it, especially if the patients, we don't have a full thorough history like they're in the ER, so we're going to give it. So how do I know it works? All of a sudden, their heart rate speeds up. So now if their heart rate was slow to begin with, they could be like a little drowsy in and out of it. And then so what you're going to see standing in the doorway is the patient's going to kind of perk up. They're going to kind of wake up a little bit, right? They were a little bit more slow to respond to your questions, and now they're acting kind of more appropriate in their speed of reactions to things, okay? So you're going to observe for those relief of symptoms related to bradycardia. So what are you going to look out for? So if this is, these are the adverse effects. Now, are they like super, super bad, like we're not going to give it? No. But dry mouth, blurred vision, urinary retention, we're going to be watching that Foley bag. If they have a Foley and they haven't urinated in a couple hours, remember how many cc's, mLs per hour of urine should you at minimum make? Well, if you're not producing any urine over the course of 3 hours and you're getting fluids and stuff, well, then we need to think about that, okay? So no reversal agent. So adenosine, remember it's a sign, looks like a sign, adenosine. We use this for SVT, okay? So first time we're going to give 6 milligrams IV push. This is the one, remember, that like you give it and it's like, stop the heart rate completely for a second or two. And then hopefully it starts beating afterwards in a slower rate, not as fast as it was before. If that 6 milligrams doesn't work, we're going to give 12 milligrams if needed, okay? This is IV rapid push. And that's going to slow the conduction through the AV node, okay? So there's my little mnemonic for you guys to remember. It's like stop the heart rate. And then after you stop, you go slower. Don't be so crazy and go so fast. So the method, before we give it, why would we want to do this if they're not an SVT? So they need to be an SVT, right? So then we're also going to do baseline vital signs because we need to know if we're going to slow it down and how much, if it worked, because we may have to repeat the dose, right? So, and we also need to make sure we have IV access secured and prepared for rapid administration, meaning if they have like a little peripheral IV hand, like teeny tiny thing, it's not going to get to the heart fast enough. So we need to have a large bore IV, at least in the AC or a central line, something where if we push it really, really fast, it can get to the heart rate before that half-life cuts off, okay? So how do I know it works? I'm watching the cardiac monitor, and all of a sudden it went from really fast to kind of like a normal rate. That's how I know it worked. Also, the patient is going to be like super anxious, and now all of a sudden they're like, oh my gosh, I feel so much better. Okay. So like you're going to see those kind of things. So the reactions you're going to watch out for though, if they start flushing or if they start having like crushing chest pain, shortness of breath. Also, if their heart doesn't start back again, if they go completely like loss of consciousness, loss of pulse, don't want that to happen either. Right. So hopefully their heart rate starts back up again. Okay, so now let's talk about mag sulfate. So here is something. So this is Maggie, and just go with me on this. She's riding a bike in the Tour de France. See the Eiffel Tower back there? And she's speeding through with these twisting ribbons behind her. And the reason why I say this is the Tour de France, the little bicycle race that goes through France. For some reason, Torsades de Pointes, Tour de France, I don't know. It works for me. It's the same. And then the EKG is the twisty thing, and Maggie is mag sulfate. We're going to give magnesium for torsades. Maggie that's those spinning, like up and down EKG rhythms, right, where it gets bigger and smaller, and torsades de pointes. Torsades, like the Tour de France. Anyways, okay, just go with me. If you don't want to remember it like that, you don't have to, but it helps me. Okay. So you're going to be giving mag sulfate for those things. Do we give mag sulfate for other things? Yes, we give it for asthma. We give it to like slow contractions in OB patients. Remember, at basics, mag sulfate is a smooth muscle relaxer. It like stops things it like kind of calms things down. Mag, one of the side effects is you feel like you have the flu. You feel just like exhausted, lethargic, like you have no energy whatsoever. Okay. So after Maggie does this Tour de France, what is she going to feel like? Blah, right? She's going to be exhausted. So that's what mag sulfate does, is it just like, blah, exhausts you. So you give 1 to 2 grams IV push over 5 to 20 minutes. Now, remember this. If it's relaxing all of the smooth muscles in your body, there's muscles inside your blood vessels too. So if we're relaxing those blood vessels, what's going to happen to your blood pressure? We're relaxing them. They're not so tight. They're kind of more loose. Your blood pressure can drop, especially when we give mag fast. Mag fast, we give mag fast to like help open up airways for asthma, like acute asthma exacerbation, kind of the same thing. You need to watch that blood pressure because you can tank them. Okay. Like they can drop their blood pressure real quick. So a lot of times we'll have fluids running beside them because we want to pump up some volume to kind of counteract the fact that we're about to cause loss of vascular tone. Okay. So, but for the indications for torsades, what mag is also doing is it's stabilizing those cardiac membranes because of the magnesium deficiency. Okay. Side effects, flushing, hypotension, and respiratory depression, because again, everything's opening up and chilling out and smoothing down, which is great if you're having asthma attack, not so great if you're just breathing normally to start with. Okay, so what are we going to monitor before? Obviously, that they have a magnesium imbalance or they're in torsades, right? We want to also check that MAG level, because if their MAG level is high, why would we give MAG? It might cause other issues, right? Too much MAG. So contraindications such as severe renal impairment, we want to make sure creatinine and everything is kind of baseline, okay, because it can affect the kidneys. So how do I know it's working? Their cardiac. I know these are all kind of easy. The cardiac monitor is back to a normal rhythm. Yay! So you're going to see signs of stability. What are we going to watch out for? Again, hypotension. All of a sudden they became unconscious. That's not a good thing after you gave MAG. Did we just bottom out their blood pressure? We want to recheck their blood pressure afterwards, because in fact, we're probably going to be checking it like every couple of minutes for at least the first hour after. If we gave MAG that fast, we're going to be checking it pretty frequently there right after, just to make sure that everything is stable vital signs wise. Okay. No reversal agent. So dopamine, remember that's dope. If you remember that, the little picture at the bottom. Okay, so what is dopamine? Dopamine is a med that's used to manage shock and low cardiac output by increasing the cardiac output, making the heart better, more efficient, right? So it's administered IV via IV infusion at a rate of 2 to 20 micrograms per kilogram a minute. Dopamine acts on various adrenergic receptors, enhancing that contractility or the squeeze of the heart and improving blood flow to vital organs. So you need to be careful and watch out for the side effects like tachycardia, arrhythmias, and hypotension. So if the patient develops the tachycardia, you might have to adjust the infusion just to kind of like manage and decrease the side effects a little bit. So there's your little picmonic. Remember, he's playful and he's happy because the heart is happier and able to do his job better, right? By squeezing out more blood. So before you give dopamine, how do we know? Other than the 5 rights. First, confirm the need for it, right? So do they have low blood pressure, low cardiac output? So we want to make sure that it's actually indicated, right? So you're going to look for signs such as hypotension, decreased urine output. So like there's not enough urine in the Foley bag. They're not doing anything like that. I mean, like there's little to no urine output whatsoever. Their MAP is going to be low, those kind of things, because those are all signs of poor perfusion. And that's what's needed that's when you need dopamine to increase those, right? So you're also going to check that heart rate, blood pressure, and the rhythm, the cardiac rhythm on the monitor, because you want baseline measurements before you give this, right? So this is going to help you tailor that infusion, because a lot of times you do titrate this med too. So, obviously you need it to give it IV, and make sure it's in like a large IV, not like a small one. So after I give it, how do I know it worked? Okay, obviously cardiac output is going to look better. So what am I going to see in that? If somebody's cardiac output is better and they're perfusing better, what does that look like in real life? Standing across the room, the patient may be more awake. Their skin color, they may have been dusky and pale. Now they're a little bit more pink, right? We might now have better urine output. Like before they didn't have any urine output. Now all of a sudden their Foley bag is filled with urine. They might be more awake because we're actually getting blood and oxygen to the brain. They're more coherent. All of those are signs that we increase that heart rate. I mean, we increase the heart's ability to get the blood and oxygen around the body. Great. So what am I going to look out for? Detecting those reactions. Okay, tachycardia, arrhythmias, hypotension. So it causes it can cause hypertension, but it also can cause hypotension because it can cause arrhythmias, and then the heart rate won't pump effectively. So they need to be on a monitor. We need to be watching the monitor when they're getting this, okay? And there's no reversal agent. So now norepinephrine, Levophed. This is a super common med, especially for patients with shock. You are going to see, people will call it Levo for short. You'll see Levophed all the time. So this little picture, okay, this is norepinephrine. This is Nora, the epic vasoconstrictor, okay? So like she's like super strong and she can lift things way up in the air. She's raising things up like your blood pressure. Okay, so Norepinephrine, primarily used in things like shock and severe hypotension to increase the blood pressure. Dosage ranges from 0.1 to 0.5 mics per kg per minute, and this is another one that you're going to titrate. Typically, the order is going to come titrate this med between these ranges to maintain a map of at least 60 or whatever, map of 85, whatever they want the mean arterial pressure to be, you're going to be titrating this. So obviously hopefully they have an ART line. So we have continuous measurements of pressures. So then we can titrate this up or down as needed to maintain very specific pressures in the system. Okay, so norepinephrine acts as a super strong, potent vasoconstrictor. But when you make the tubes smaller, same amount of volume of fluid, the blood pressure goes up, right? So that elevates your blood pressure and increases and improves the perfusion of getting the oxygen actually to the tissues, right? So some of the side effects, though, include hypertension, arrhythmias, and tissue necrosis if it extravagates. So if it goes outside into the tissue, so like you have a blown IV and it gets out there, remember it's causing vasoconstriction. So if the med is getting out into like near the capillaries and like the skin and tissue around, like say your hand or something like that, it's going to cause vasoconstriction. So now no blood is going to get to those tissues, right? And so it can cause necrosis. So this is another one. We want it in a large IV. Really want it in a central line. Okay. Can we start it in like a 18 gauge in the AC? Sure. But that's like we're getting it started so that we're going to perfuse while somebody's starting a central line. But again, go by your policy of your institution. So the picmonic right there, like I said, that's Nora. She's lifting. So like the blood pressure, she's raising it, right? And so she's also super strong. So norepinephrine, remember, works by increasing vascular tone. So like she's toning up her muscles. See there? See how that works? Yeah. Anyways, hope you can remember that. So before we give Levophed norepinephrine, what are we going to look out for, right? Obviously, that their blood pressure is low, because if it's high, we're not going to give it. So we want to make sure that their blood pressure is low, okay, and their heart rate. And we also need the correct IV infusion setup. Like we need large bore access. We are not going to be starting this in like a teeny tiny IV in the hand. Absolutely not. We're going to need a central line ASAP. So how do I know it's working? All of a sudden their blood pressure goes up. So if they're not perfusing, their blood pressure was down. They're not getting they're not getting blood and oxygen to their heart and their lungs and their kidneys. Like you might have a decrease in level of consciousness. So then when you give them Levophed, all of a sudden now they're a little bit more awake and alert. Same thing as kind of before with like dopamine and stuff. So all of a sudden they went from no urinary output to all of a sudden now there's urine in the Foley. That's awesome. It's working. Their cap refill is now really fast. Before it was like 10 seconds or something, like whatever. They may have had like pale mottled skin in their periphery and now it's warm and pink again because we're perfusing things. That's great. We want to see that, right? Okay, so anyways, how are we going to know things went bad? We're going to be looking for like tissue necrosis around the IV site, especially like if it's not in a central line. But anyways, and there's no reversal agent. So that's about it. Okay, so vasopressin. This used to be more commonly used. It's not first line anymore, but some people will use this in cardiac arrest as an alternative to epinephrine. If you somehow run out of epinephrine, can you give vasopressin? Yes, you can. Okay, so vasopressin is rapid IV push. Okay, it can act as a vasoconstrictor, a lot like epinephrine, increasing that systemic vascular resistance and potentially improving perfusion and pressure. So it's no longer recommended as a first-line treatment in the ACLS guideline. I forgot how many ACLSs ago that they took it out, but you might still encounter it in practice in real life. So we want to include this just because you need to become aware and familiar with it, okay? So some of those side effects: ischemia, hypertension, decreased cardiac output, which would require careful monitoring. So that's because it can cause some arrhythmias and stuff. So before we give it, okay, we need to confirm that it's actually needed, right? Blood pressure low, heart not working, okay, that kind of thing. You also need this in a larger IV. We do not want to push this if the heart's not working, we're going to push it and just hope that IV is great. But we want to make sure the IV is patent and good before we give it, okay? How do we know it's working? you're going to see an improvement in perfusion and the hemodynamic status. Vital signs are going to get better. They're going to, those same things I'm talking about. Their heart might actually work good enough to make the cap refill get better, to get urinary output, to maybe have a difference in level of consciousness or neurostatus, those kind of things. So, but the big thing is return of spontaneous circulation. Like I said, this is used sometimes in replace of epinephrine. Well, it's not so much anymore, but it's an alternative to epi in like a code situation. So calcium chloride. What I want you to think of calcium chloride, that's Cal. He is the heart's knight and shield. He's the knight in shining armor for the heart. He protects that heart with his life. So calcium chloride. Calcium chloride we give, a lot of times it protects the myocardium and a whole lot of electrolyte imbalances. But in a code situation, it helps if you are coding because of low calcium or because you did a calcium channel blocker, which then makes it where your heart can't do the calcium, potassium, like channels for the heart contractility and all that kind of stuff. We're going to give calcium to like overrule that. And so that the heart can still pump. Okay. So side effects, obviously, if I'm giving calcium, the side effect could be too much calcium. It can also cause hypotension and local irritation to the area. It can burn the IV site that it's going into. So the med method, before we give it, we're going to check lab values for hypocalcemia. So if their calcium isn't low and it's high, we're not going to give calcium, right? Also, we're going to look at the ECG. We're going to make sure that there's some arrhythmias going on that are indicated for it. Okay, so how do I know it's working? Okay, well, if it's because of hypocalcemia, we do a repeat lab and the calcium levels are up into normal range, right? We're also going to see the heart start beating more normal. So if we took a whole bunch of calcium channel blockers, like somebody overdosed on calcium channel blockers, so they got too many, then obviously that's going to slow their heart rate down. So you're going to see the heart rate beating faster when we give calcium chloride. And so what are the reactions we're going to look for? Hypercalcemia, hypotension, local irritation. So what that would look like is, I'm sorry for a second. So if the patient develops abdominal pain, excessive flushing, that might be a sign that they have too much calcium or hypercalcemia. So flushing is one of those things, or abdominal cramps. Now, sodium bicarb, if you remember this was for, it's like baking soda for the blood, right? So it's going to lower that pH. It's for those patients in like metabolic acidosis. So after somebody's heart has stopped for a long time, you weren't able to get oxygen to the tissues a whole lot. You become acidotic. Okay. You have some, when the cells are breaking down around your body and places in your organs and tissue because they didn't get oxygen. So they're dying off. They're releasing hydrogen ions, which is making you acidotic. So sometimes after like a prolonged cardiac arrest, or let's just say you've had your blood pressure so low for so long because you were in a form of shock that before we were able to get it back up again, you had some like death of tissue around your system, you're going to be acidotic. And so this is one way to counteract the acidosis is by giving you sodium bicarb. So it neutralizes that acid in the bloodstream. So before you give it, right, we want to make sure you're acidotic, because if you're alkalotic and we give it, we're going to make it even worse. So a pH, we want to get like a ABG or VBG. Hopefully it's ABG because that's way more accurate to make decisions off of than a venous blood gas. But so get an arterial blood gas if you can. And then we're also going to be looking for like those other signs of alkalosis. So again, a lot of it is straight up lab values. So how do I know it's working? The blood gas improves, right? And they're not so acidotic. So remember, if somebody's acidotic, a lot of times your body will naturally start trying to breathe faster to like blow off more of those hydrogen ions, like get some more of the like acidosis off. So you might see like a more calmer respiratory effort, those kind of things. So what you're going to look for is the signs for metabolic acidosis, hypokalemia, and fluid overload. So fluid overload, you're going to see like bounding pulses, maybe crackles in the lungs, those kind of things. So let's see, is there anything else I needed to say about this? Nope, we're good. Okay, so now let's talk about those cardiac arrest algorithms. So I can read these to you, but I'm not going to insult your intelligence. You can read them yourselves. The thing is you just need to become familiarized with we're going to go over 3 different algorithm types. There are more for ACLS, okay? But the only 3 that we're going to cover in this class are for cardiac arrest, for bradycardia with a pulse, and tachycardia with a pulse. Okay, so those are the 3. There's like stroke algorithms, and then there's post-cardiac arrest care. There's other algorithms that are involved in the actual ACLS that you would take the course with AHA. We're not going to go over those right now in this course. So you can Google them. They're in Blackboard. But basically, what these algorithms are, they're systematic approaches to managing the different situations. So for the cardiac arrest algorithm, this is for VFib, pulseless VTAC, and the first step in it is administering high quality CPR. It includes options like administering epinephrine every 3 to 5 minutes, and it's going to tell you to like consider things like amiodarone or lidocaine for arrhythmias. And then also it's going to tell you, it basically just guides you in how you go. So on this next slide right here, this is your algorithm. So this is after BLS. You've no pulse. You've started CPR. So now we're going to go into the ACLS algorithm. So we've already started CPR. We're going to give oxygen, attach them to the monitor. So do they have a shockable rhythm? If yes, you go to the left-hand side. If no, you go to the right-hand side, right? So then it's telling you what to do, and you kind of follow this along the way. Okay, so you just keep doing these things until you get ROSC. The goal is return of spontaneous circulation. The goal is for their heart to start beating again, right? So on the left-hand side, it kind of gives you some reminders of these things. Okay, so now when you get all the way down to the bottom, it's you start to think of reversible causes. They call those H's and T's. Like, okay, so we've already tried all these other things. We've given these meds. So what caused that heart to stop? So on the very bottom of that column with the gray, there's H's and T's. These are some things that you need to consider. And then you treat that and maybe the heart will fix itself or start beating again. Hypovolemia. Did they lose a lot of blood or a lot of fluid? Do we need to replace it? Hypoxia, for whatever reason. Hydrogen ion. So their acidosis, right? Hypo or hyperkalemia. Like, do we need to fix that? Hypothermia, do we need to rewarm them? Tension pneumothorax, do we need to put a chest tube in them? Tamponade, cardiac. I know you don't know what these are. That's why I'm not going crazy into them. You don't have to necessarily know what they are right now in the course. Just kind of make a list so that you can tell me what are some of those H's and T's that you would consider. I'm not going to make you define them right now. We'll define them in subsequent parts of the course. But right here, you just need to know what are some of the H's and T's. So now the next algorithm is bradycardia. Again, this is with a pulse. If it doesn't have a pulse, you're going into cardiac arrest algorithm. So this is bradycardia with a pulse. What do? You're going to follow this algorithm. So you're going to assess the appropriateness for clinical condition. And are they symptomatic, less than 50 beats per minute, and they're bradycardics? And then we're going to try to go down here. And this is what you do. And these are the options you have off to the side. So if you get down there, so you have persistent bradycardia causing hypotension, altered mental status. So they're symptomatic and their heart rate is slow. First thing that we're going to give is atropine, or we can give dopamine, or we can give epinephrine, right? So this is what you follow, and this is what guides you in how you treat these patients. Now, if their heart rate is low, but they don't have any of those symptoms, we're just going to monitor and observe them. You see, like in the middle from the red off to the left, monitor and observe. So again, become familiar with this algorithm. The third algorithm is tachy with a pulse. Now, this is any tachycardia, but they still have a pulse. Remember, if they're tachycardia without a pulse, we're going to the cardiac arrest rhythm because their heart is not beating. But as long as their heart is beating, we're going to follow this algorithm, okay? So this is over 150, and then we're going to say, okay, do they have an airway? So like we're going to make sure they have an IV, 12 lead EKG, those kind of things. And then, okay, so what's going on? What's causing it? Hypotension? Are they a sign of shock? Is acute heart failure? And you're just going to follow the paths, and you're going to follow the indications. So again, become familiar with these algorithms just so that you can kind of understand what you would do if things are said here versus there. I will tell you the one that I care about. I want you to kind of have general understanding of the Brady and the tachycardia with a pulse, but the one that I really want you guys to really know is the cardiac arrest with the pulse. You need to know how to do a code. This is the one I want you to be an expert on, okay? Cardiac arrest algorithm for an adult, okay, with a pulse. So in summary, we talked today about those medications, kind of went over how those rhythm interpretation is important in identifying and knowing what to do. You need to go over those algorithms that we just talked to you about, because those are the protocols for treating those symptoms. We also went over the med method for each of the meds, just so you kind of have a general understanding of the before and after of what you as a nurse is going to assess. Okay. Now I want you guys to, in your mind, practice for a mega code. You will be having a skills lab session where you're coming in and you'll be given a scenario and you'll be running through a mega code. So familiarize yourself with the different roles. If you are the leader, you will be running the algorithm. So we will have printouts. I would suggest you print them out and bring them with you of the algorithm so that you can follow it. You need to have a watch on in lab, because if something's every 3 to 5 minutes, you need to be writing it down. You can also delegate to somebody to be the documenter, and then they need to say, and let me know when it's been 3 minutes so we can give epi again. And so these are some of the things. You all need to be prepared to be the leader in that role for a code. So you really need to familiarize yourself with this algorithm. This is putting it all together right here. You need to be able to know what the meds do. You need to be able to read the algorithms on the screen to be able to know what to do for these things. You need to give epi or amio or lidocaine. Okay. We also will talk more about the actual shocks defibrillation. You can read it on here about how much shock would be advised, because it's not deciding. You decide how much shock to give. It's all on these algorithms. Okay. So you'll be able to follow this. But my biggest thing is remember that the leader sets the tone for the whole team. You've got to stay calm. And there's a phrase, and it may sound a little crass in this, but there's a phrase that a lot of ER nurses say is you can't kill dead. Okay. So if somebody already doesn't have a heart rate, right? They're already dying, dead. We're trying to bring them back. Right. So you do the best you can, and hopefully we're able to get ROSC. But if we don't, it's we did the best we could with the information and the tools and values and resources that we had in front of us. Sometimes we can't save patients, as you guys know. We try our best. But the more you become familiar with these algorithms and the meds and interpreting these EKG, the arrhythmias and stuff on the EKG, the more confident and calm you'll be in a code situation. So with that said, you've now completed the third and final module for ACLS for this course. Okay, so don't forget that there is a quiz for you guys to do online that's due by the end of the week on Blackboard. If you have any questions, please post them in the discussion board.